Hi, I'm Dr. Ambreesh Chawla from the Cleveland Clinic. I wanted to share a couple of interesting cases of new onset eosinophilic fasciitis that I have recently seen in our rheumatology clinic. My goal is to highlight various presentations and complications which may be seen in association with this rare disorder. Case 1. A 46-year-old female with the recent diagnosis of COVID-19 presented to Cleveland Clinic's rheumatology clinic with new onset worsening distal upper and lower extremity pain and discomfort. She noted that shortly after her diagnosis of COVID-19, she began to experience severe allodynia to light touch over her forearms and shins. Laboratory testing revealed 25% eosinophils on CBC with mildly elevated markers of inflammation and borderline positive rheumatoid factor. Because of worsening allodynia, polyarthralgia, and polymyalgia with persistent eosinophilia, the patient underwent an aggressive workup for eosinophilic-related conditions, including parasitic infections, strongyloides, vasculitis, EGPA, hypereosinophilic syndrome, and allergy testing. Physical exam revealed skin thickening and deep induration of her distal extremities, sparing her hands and feet with a peau d'orange appearance of the skin of her forearms and shins. MRI revealed fascial thickening and edema, predominantly involving the deep peripheral fascia superficial to the muscles in the forearms and lower legs. The patient subsequently underwent a full-thickness biopsy, which demonstrated perivascular infiltration of histiocytes, lymphocytes, and plasma cells. Based on these findings, she was diagnosed with eosinophilic fasciitis. The patient was then started on high doses of oral prednisone, 1 mg per kilogram per day, in addition to methotrexate. Treatment led to normalization of the eosinophil count and skin softening on subsequent evaluation. Case 2. A 62-year-old male with a past medical history of multiple sclerosis and family history of rheumatoid arthritis presented to our rheumatology clinic for a 2-month history of bilateral upper and lower extremity swelling with associated skin tightening, sparing the hands and feet. On review of symptoms, he endorsed worsening joint pain. He denied any history of Raynaud's phenomenon, acid reflux, rashes, sicca symptoms, chest pain, or shortness of breath. Labs revealed elevated markers of inflammation, positive ANA with an unremarkable ENA, negative scleroderma and myositis-specific antibodies. Interestingly, he was found to have an elevated aldolase with a normal creatine kinase muscle enzyme. His CBC did not show an elevated eosinophil count. On exam, while asking the patient to raise his arms, a characteristic groove sign was appreciated, demonstrating linear depressions along superficial veins. Full-thickness biopsy of his left forearm demonstrated dense perivascular lymphohistiocytic infiltrate without eosinophils. Despite a lack of eosinophils on biopsy, a diagnosis of eosinophilic fasciitis was made. Treatment with high doses of prednisone and methotrexate led to significant softening of his skin. 1 month later, our patient was found to have new onset pancytopenia of all 3 lines. Methotrexate was suspended, but despite this, he continued to have worsening pancytopenia. He was admitted to the hospital where he underwent bone marrow biopsy, which revealed a hypocellular marrow. He was given a diagnosis of aplastic anemia and started on cyclosporine by our hematology colleagues. In summary, eosinophilic fasciitis is a rare disorder of unknown etiology associated with skin thickening and hidebound quality of the skin. Unlike scleroderma and eosinophilic fasciitis, skin of the hands and feet are typically spared without sclerodactyly, and there is no association with Raynaud's phenomenon. On exam, patients have a normal nail fold capillary microscopy. The onset is typically acute, with swelling and induration of extremities. Strenuous exercise, initiation of hemodialysis, recent viral illness may trigger eosinophilic fasciitis. Peripheral eosinophilia may be absent during clinical presentation of EF, as seen in Case 2. Peripheral eosinophilia is transient and does not correlate with disease severity. Eosinophilic fasciitis can have normal serum CK levels with elevated aldolase levels, as we saw in Case 2. Hematologic disorders, such as aplastic anemia, myelodysplastic syndromes, myeloproliferative disorders, myeloma, paroxysmal nocturnal hemoglobinuria, can be associated with eosinophilic fasciitis in up to 10% of patients and can be the presenting manifestation. MRI can help to discern fascial thickening and guide location of a biopsy. Full thickness biopsy, skin to muscle, can help confirm the diagnosis. Both cases today highlighted that tissue eosinophilia is not always seen on histopathology. Differential diagnosis for eosinophilic fasciitis includes systemic sclerosis, scleroedema, scleromyxedema, eosinophilia myalgia syndrome, nephrogenic systemic fibrosis, graft versus host disease, and patients with eosinophilic fasciitis generally respond favorably to high doses of prednisone with prompt initiation of steroid-sparing therapies such as methotrexate, mycophenolate, and/or IVIG. Thank you.